Good evening, and welcome to tonight's panel discussion. COVID-19, Practical Guidance for Summer 2020. We are the Parish Nurses. I'm Sharon Morgan, a registered nurse and nurse practitioner for more than 35 years, and this is my colleague, Carrie Allen, a registered nurse for more than 47 years. Together, we have worked as Parish Nurses for the last 3 years. For those of you not familiar with the Parish Nurses, the Lyme Parish Nurse Program was founded in 2006 and is dedicated to the enhancement of the health and well-being of the Lyme community and the congregants of the Lyme Congregational Church. Our practice is multifaceted and includes the education, advocacy, health promotion, and coordination of care of both individuals, families, and the community. We work as a branch of the health ministry of the Lyme Congregational Church and are funded through the town of Lyme and many generous donations, both local and regional. There is no fee for our services.
Thank you, Sharon. Sharon and I are so happy to be co-sponsoring this crucial discussion tonight, along with our colleagues from the Health Ministry and the Converse Free Library. We wish to express our many thanks and our appreciation to them, especially to Dr. John Sanders and Judy Russell for making this event possible. We also wish to thank the panelists for giving generously of their time and expertise to be here with us tonight. And we send our sincere thanks to Dr. Margaret Caudell-Schlossberg, who, as our Emergency Medical Management Director, has worked tirelessly leading our Lyme COVID Response Task Force to coordinate town efforts keeping Lyme healthy and safe throughout this challenging pandemic. So now to Judy Russell, our moderator.
Hi, I'm back, and I am going to be a quiet presence in the background during the course of our program. When needed, you may see me pop up, but the program is for the panelists, and they have the expertise to share with you. I want to take a moment before we begin to introduce them and let you know a little bit about them. I'm going to introduce them in the order in which they will be speaking as well. So beginning with Dr. Elizabeth Talbot. She is the professor of medicine at the Geisel, a professor of medicine at the Geisel School of Medicine. She is an infectious disease and international health specialist, and she is the deputy state epidemiologist for the New Hampshire Department of Health and Human Services. Next, we have Antonia Altomari. She is assistant professor of medicine at the Geisel School of Medicine, infectious disease and international health specialist, and the Dartmouth Hitchcock Hospital epidemiologist. Kenton Powell is assistant professor of internal medicine at the Geisel School of Medicine, and he is the lead at the DHMC Lyme Clinic. And our own Margaret Caudell-Schlossberg is our emergency management director here in the town of Lyme, and we are very grateful to her and all the work that she has done on our behalf. At this time, I'm going to ask Dr. Talbot to begin the presentations.
Can you confirm that you can see my slide?
We can.
Great. Really, thank you very much for inviting me to be here in this community session, because that's where things can happen and things can change for this wily virus. Thanks to my co-presenters as well for allowing me to lead with some overview statements, and I'll try not to take too much of the time, but I do think it's been such a really historic event that it warrants some review as we approach this on the global, the state, and even that local level. So it's been a long time now, but not that long, that we've been looking at this horrible little critter shown here. I think it was December 31st that there was first a public announcement around this through the World Health Organization country office. There's some question about whether it had been circulating much longer than that. But we found out very quickly thereafter that this was a never before seen bat cold virus, yeah. And there were some initial public health activities that occurred in the city of greatest impact in Wuhan city, where these decisions for quarantine probably resulted in some of the initial global dissemination as people thought they better get home as fast as possible. It was really very shortly thereafter that we had our first case in the United States. You remember the announcement from Seattle, January 20th. And we started worrying that this virus had an origin from wildlife. There are multiple reasons for that, but that is of great public health concern when we recognize a zoonotic infection, an infection that comes from an animal and can newly infect a human. Again, because of the way the virus appears when you sequence it all out and take it all apart, it was clear that it was related to very common Asian and African bat species, but that it needed an unusual animal, the pangolin, to give it one of the tools it needed to actually successfully infect humans and allow person-to-person transmission. That story continues to be told, but I think that there's some pretty good evidence that these two animals together have allowed for this species jump, in spite of some of the rumors and conspiracy theories around it being a man-made virus. I've seen no evidence for that. Back to the timeline, because of these features coming together as they did, there was a United States public health emergency declared. And several days later, we had a most unusual presidential proclamation to restrict persons coming in from China. By February 26, we recognized for the first time community transmission, again in the Seattle area, but also in California. Not long thereafter, we had our first case in New Hampshire. I can hardly believe it was just March 2nd. And now everything is BC and in the COVID era, before COVID and after. It was a few days after that the World Health Organization declared a pandemic, although we all saw that that's what was happening. And we moved into state of emergency in the United States and also shortly thereafter in New Hampshire. So this is the next few months, and things are, marching on. We have a new drug. So remdesivir is the drug that has been demonstrated in several studies now to show utility and efficacy in reducing mortality potentially, and also the duration of stay in the hospital, and people get better faster. In contrast, that first drug we heard about that might have some activity, that malaria drug, hydroxychloroquine and chloroquine, has now had multiple negative recommendations. We are actually moving in many states, as you know, toward reopening. May 11th, New Hampshire was declared as phase 1 for reopening. Remdesivir is now distributed across all hospitals at the ready. And only a few days ago, it was declared that the stay-at-home order had expired, and the new program that we'll talk about for life in the Upper Valley and beyond began, the Safer-at-Home program. We'll talk about that. If you want to know the details of these openings, the latter half of June is multiple releases of guidance on how to go to restaurants, have a wedding, go to day camps, even overnight camps. Movie theaters, performing arts, and amusement parks are also slated to open under guidance that is available at the website as shown. So here we are globally. This is today's tally, where it's been a remarkably fast time to go from 8 million to 9 million cases, just 1 week, for that huge jump, largely driven by Brazil, United States, and India. You know that the death count is fraught with some flaws in terms of accuracy, but it's approaching 500,000 cases. I think it's worthwhile asking why there has been such global spread. I've seen some of the questions that you pre-positioned for this night, and I think some might be answered here too. There are features of this virus that just make an epidemiologist hair stand on end. I mean, this has got some terrible tricks to it. First, that there's a tremendous ease in transmission when diseases are transmitted by these respiratory droplets. This is the vast majority of how this virus transmits globally. Lots of questions about how else it might be transmitted. It does appear that fomites or objects can play a very small role. That is, if someone who has an active infection or an asymptomatic infection touches their own nasal secretions, oral secretions, and then touches a doorknob or a handrail or a pencil or a keyboard or whatever, then somebody else might come along in a short interval, touch that and auto-inoculate themselves. That is, touch their own mucosa of their face, eyes, or nose. There's also a tremendous ease of importation. We've seen this again and again, where we could move around our planet with dizzying speed. So this virus has gone along for that ride. We also have a population that's completely immunologically immune. There is no pre-existing immunity. Everybody seems to be able to get this virus. There are differences in susceptibility, but by and large, we can't depend on any herd immunity. There's also a tremendously high attack rate because of this terrible phenomenon of a person being able to transmit that virus even before they have any symptoms at all. So it looks like even out 3 days before the onset of symptoms and the recognition of illness, a person is shedding viable, that is, contagious virus. We also have identified with great dismay that even if you never develop symptoms, you might have this infection and transmit it unwittingly. I think that we've also seen some early rapid rise in disease globally because of this terrible lack of testing we've all suffered through. Lots of reasons for that, and I know you have questions about that. I hope we can talk more about it. Our own public health agency, the CDC, has put out a statement in their weekly morbidity and mortality weekly report that I think summarizes this in a text that just various factors contributed to the accelerating spread, including travel-related importation, large gatherings, introductions into high-risk workplaces in densely populated areas, think of Manhattan and some of the meat processing plants, and cryptic transmission resulting from limited testing and asymptomatic and pre-symptomatic spread. Targeted community-wide mitigation efforts are needed. Yeah, so we'll come back to that. You likely have your own way of tracking this virus. I think this is a pretty fancy way where you can see this represents the United States, each state roughly in the shape of our United States. So, of course, New Hampshire, Vermont, and Maine up here in the Northeast, and the trajectory of our epidemics where New Hampshire is coming down, Vermont is coming down, Maine is coming down, but there are some very concerning rises, particularly in the south of the United States. Really bringing it to our own jurisdiction, our own home in New Hampshire, we've now reported out more than 5,500 confirmed cases. We've recognized that about 6% of our cases in New Hampshire have died of this disease. We also have seen quite a burden on our healthcare system for the fact that 10% of our cases have required hospitalization, and some of that has been very intensive, such as in the intensive care units. We've greatly ramped up testing in the two ways that testing can occur. To be very intentional when we talk about testing, the two ways include the polymerase chain reaction, the PCR. This is the test that diagnoses you if you have symptoms and you want a diagnosis. Antibody tests give you the answer of whether you might have seen this disease in the past. They really have no role in clinical testing. We just don't have any need, don't see any need to test people using antibody. It's largely curiosity that's driving people, but we just don't have any action that we can take on the basis of a positive test. So with that, I want to turn to control strategies because that will be the remainder of our focus. I think you've seen multiple curves where we can flatten the curve, dampen the curve, reduce the number of cases, and spread out how long these cases are going to occur in so we don't overwhelm our health system. And this is a nice graphic that has evidence behind it, but is largely a model. That is, a bunch of mathematicians put numbers into a smart computer and spits out that if we do nothing, we'll see the black line. But of course, we've done a fair bit. We've closed schools, we've instituted isolation and quarantine, we've put in place social distancing and such measures. So we have a plan to reopen. I'm sure many of you saw the White House announcement about this, and there are certain requirements to move through these phases, and it's highly detailed. But in fact, as an epidemiologist at the state jurisdiction and regionally engaged, I can tell you that states are just moving. You know, this feels as though it might be somewhat obsolete, that once this opening has started, it's going pretty fast and does not follow these rules. In New Hampshire, we do have a new executive order called number 52 around behaviors that should guide us and keep us on the lower epidemic curve. And that is that people older than 65 and those with underlying health conditions such as hypertension, heart disease, medicines that suppress immune systems, these persons are still advised to stay at home. You can leave for essential needs. I know a lot of grocery stores accommodate that, right, at special hours. Everybody should be wearing a face covering when out. And everyone needs to monitor for illness and call ahead to healthcare, which we'll talk about how to do that in a few minutes. So everyone has to practice social distancing when leaving home and still limit out-of-home trips. There's guidelines online about what to do and how to do it. But again, the key, I think, is that monitoring for illness and declaring yourself early so we can get a jump on any transmission that might have already occurred. So those are the slides that I thought could frame things for others to now launch from. So thank you for your attention to that. And I'll turn it over. I think it's Antonia who's next, isn't it?
It is. Thank you, Dr. Talbot. I'm happy to be speaking to my local community, and I think Dr. Talbot certainly laid the framework of what we've been experiencing, and thought I would just add some pearls of kind of what we've been experiencing locally at DHMC and try to answer some of the most common questions that I've certainly been getting on a day-to-day basis. So March 2nd will certainly go down in my history book as a day I will never forget, because that first case in New Hampshire was at Dartmouth Hitchcock, and I'm sure you remember as well. And a lot has changed since then, but I'd like to also say that there was a lot in place, and that this case was certainly identified and isolated appropriately because of everything we've been planning for in our epidemic response for many years. In fact, Dr. Talbot was instrumental in creating our epidemic response plan back when SARS-1 was an issue, and we've taken that and modified it over the years for the threat at hand, whether that be Ebola or novel avian influenzas, or even local outbreaks like Coxsackie virus, things we started to see at the college and stuff like that. So to say that we were able to respond extremely quickly using this plan and knowing what we had to do. So I'm proud to say that we have pretty strict screening scripts that we do both over the phone, at reception desks, and at the doors. So if anyone has ever been to any of our DH facilities, it's going to look different, it's going to hear different. And it's going to be a little different, but all of this is in mind in order to keep everyone safe. And yes, we are open and we are safe. We had closed down some elective procedures in the beginning to really offset the need for bed capacity if we were going to experience a surge in the number of patients that were being admitted. But we are now reopening up slowly to come back to capacity to serve everyone whose procedures or appointments had to be delayed. The other thing that we did that you should know is that we got over 3,000 healthcare workers trained in very specific personal protective equipment. And this is something you may see that is different from before COVID times, in that we're practicing this new universal precaution that we had not had really before, where in line with the state recommendations to be masking at all times, everyone entering our facility is asked to don a mask, and patients and visitors will be given cloth masks while our healthcare personnel will be in medical masks. But your providers may also be wearing face shields, and this is just our general practice right now in order to protect us from any asymptomatic or pre-symptomatic COVID that we may not recognize because people may not have the typical symptoms. I wanted to touch a little bit on testing because I know a lot of questions have come up around testing, and back in March, early March, we were able to quickly implement a mobile testing unit that is still in place today for anyone who needs the nasal swab testing because they're concerned for active disease. Our lab was able to pivot on a dime to get in-house testing created, validated, and running, not only for the PCR, but also for the antibody test. And really understanding the differences there are that the PCR is really looking for active infection, and that's the test that requires the nasal swab. The antibody test that we have looks for that antibody response or that immune response to infection. And it really just tells us, yes, you've been exposed and you've probably had it in the past, but connecting the dots as to whether that means you're immune or not is still what we are hoping to gain some insight in with research that's ongoing. So right now we can't say that even if you have the presence of antibodies that either you're immune and won't get it again, or how long do those antibodies even last. So we're hoping with more data that's coming forth that this will be useful in the future, but like Dr. Talbot said, right now it's fact-finding, determining perhaps the prevalence of disease in our population and in our community, but this would not change our recommendations for the preventive mitigation strategies, which include masking, good hand hygiene, social distancing, and really staying at home if you're high risk for infection. At the hospital, we do have travel restrictions for our employees as well as patients, in that with the CDC's travel advisories really limiting international travel, anyone who has traveled internationally, including Canada, is advised to quarantine for 14 days and potentially postponing any non-urgent medical appointments. Of course, if something urgent happens and you need to be seen, by all means, we will see you. And you will be asked about travel as part of the screening, and we will know whether or not we have to be concerned, and you may be isolated slightly differently than if you had not traveled. You may be aware that we've had a visitor policy that has changed over time. This again was to limit kind of the transit of people coming in and out of our facility, both to protect them and to protect us. At this point, we've loosened it slightly, and things may continue to modify as time goes on. I also, Dr. Talbot mentioned the treatment medication remdesivir, and really Dartmouth-Hitchcock has been on the forefront of a lot of clinical trials for COVID, and wanted to highlight the fact that we have at least 4 or 5 ongoing now, not just remdesivir, but certain medications that are meant to blunt the immune response, because a lot of what we're seeing in the individuals who are becoming ill, it's not just the virus itself, but it's the aggressive immune response to the virus. And so we're really looking at and providing certain medications to certain individuals as they are eligible for these different trials. And we've, as you would expect, have certainly taken care of quite a few, and they have all done really well. So I think our big message for you is that we are safe and open. So some of the very specific questions I want to get to are, well, and I've just been asked many of them just today. So what do you suggest when I do travel, or if I can go on vacation this summer? Should I take a plane, or is it safer for me to be in a car? And I think it's really hard to answer. I always ask the person, well, what is your risk tolerance, and how do you feel how do you feel about it? Because the main thing is that travel is not recommended, but if you have to, it can certainly be done safely. There's certain airlines that are requiring masking, but not all of them. To my knowledge, they're not booking to full capacity, but again, this is variable by airline. And know that at least in New Hampshire, if traveling on any kind of public conveyance, whether that is a plane, a train, a bus, that you are subject to quarantine on return just because of the risk of being in these large group settings, no matter where your destination is. So I think it is somewhat of a difficult question to answer, and I know people are itching to travel. So know that there may be some restrictions depending on the type of conveyance you decide to take to travel. On that, the question is, well, can I visit my family, my grandchildren? I haven't seen them in so long. Can they come visit me? And this is a question we have all been struggling with over the last several months. And I think, again, it's minimizing risk as much as possible, meaning that if it's possible to do these visits at a distance, but in person, then maintaining that 6-foot distance, making that visit be outside as opposed to inside, washing hands frequently and wearing masks, if possible, are really all we can do in our control to prevent this right now, short of there being a vaccine or something else we can rely on to prevent the majority of people who are still vulnerable to infection getting infected. Other questions that I've fielded over the last couple weeks in anticipation for summer are, what are some of the safe summer activities I can do? Can I do the usual stuff that I'm used to doing? So certainly outdoor activities are safer than being in a closed space, because transmission does have to do with ventilation and transmission of those particles. And if it's something you can do at a distance, even better. So certainly hiking, biking, kayaking are great activities that promote both the social distancing but get you outside. And some of the things I recommend, certainly if camping, is if there's places that you have to use that are common and shared, such as restrooms or restaurants, then certainly use a mask because we really don't want to unknowingly transmit virus to others. And the last question I want to tackle, and then I'll pass it on and hopefully get to all of your questions, are, what is the fall going to look like? And are schools going to open? What do you think is going to happen to us? And I've said many times over, it's really hard to predict an unpredictable situation, which has kind of been the story of the last several months. And all modeling is wrong, and some are helpful, because we've been modeling this and trying to predict factors day by day, and they're only as good as the variables we're putting in, and we just don't know months from now what that's going to look like. I have to say that our overall numbers in New Hampshire are looking great. They're coming down. We're much lower than we had been with regards to number of positive cases every day. But that doesn't mean that it can't ramp up as people start being less restrictive with the social distancing and the state starts opening up both societal-wise and economic-wise. So as more people start going back to work or start gathering in large groups, it's really unclear, if people aren't being good about the masking, the hand hygiene, what those numbers are going to look like going forward. And so really hard to predict, and I know the state's working really hard to try to come up with some guidance that will get us safely back into school mode come the fall. But again, it's a little too far in advance today to say with any confidence. So I think I'll pause there just to pass it on to Dr. Powell, and then hopefully we'll have some time at the end to answer more questions.
But I'd like to thank the Health Ministry and the Parish Nurses for having me here tonight, and really it's really an honor to be sharing the forum with such fantastic panelists. I also want to thank all the participants that are here. Really happy that you have an interest in trying to educate yourselves on this disease. And I think I speak for all the providers and staff at the Lyme Clinic. We're really honored to serve this community. And the community's really been fantastic to us over the years, very supportive, and we really appreciate that. And we're thrilled every day to take care of people from this community. So I'm really going to be talking a little bit about how Lyme's response to COVID is and what it'll look like if you happen to have an appointment with us. So first, as Antonia had, Dr. Altamari had mentioned, is that we're open for business. We're seeing patients in person for both routine care and for illness or injury appointments. We want to really ensure that we continue to give care as needed to help maintain your health care. And I think I really want to emphasize on the fact of really not putting off that care. We have seen in other areas, and we've seen illnesses, late presentation of illnesses because people have been fearful to come into the healthcare system. And so we really want to make sure that we're taking care of you and not putting things off. However, with the virus, we have had to make some changes to keep everyone safe, both staff and patients that are coming in. Dr. Altamari mentioned several of them, but I'm going to really talk about what it would be like to walk through everything from scheduling an appointment at Lyme to completing your appointment, and then again with the goal of keeping everyone safe and delivering the care that you're accustomed to. Right now at Lyme, we are seeing patients who have a provider at Lyme. In other words, if your primary care provider is a Lyme provider, then you will have appointments with us. However, that being said, if you are not a Lyme patient, but you need to be seen for something, you can be seen at Dartmouth-Hitchcock's 3M walk-in clinic. That includes, even if you have a primary care provider that is not at Dartmouth-Hitchcock, you can still use that clinic if you have some healthcare needs that need to be addressed. At Lyme, we are only seeing patients with appointments. We do not have any walk-in hours. However, we do offer telephone and video visits. If you're much more comfortable in having a visit in that way, we can certainly set you up to have a video visit. When you're calling for an appointment, Dr. Altamari also had mentioned how there will be some screening. So the scheduling secretary will ask you questions about if you have any symptoms that would be consistent with COVID. And now I'm going to kind of break down how that fork in the road comes. So if you call and you do have symptoms that are consistent with COVID, you will be transferred to speak to one of our nurses. And the nurse will gather more information. If the nurse confirms that thinks that you may have symptoms that are consistent with the disease, one of several things may happen. First, you may be offered a phone or video visit to be scheduled with a provider to sort of evaluate you and see if you need any testing or further level of care. You may also be offered actually a test, which we would set up through Dartmouth-Hitchcock with the drive-in clinic, the mobile clinic that Dr. already had spoken about. And then we would await those results before having you come in for an in-person visit. Or finally, if you have symptoms or concerns that we feel that you are ill enough that we really feel that someone should see you in a more urgent matter, and we don't think that you need to, we don't think that you need emergency department care, but you do need to be seen, we can set you up to go to Dartmouth-Hitchcock at 3M. We have a respiratory clinic, which allows providers that will wear a higher level of protective device that Dr. Altamari had alluded to. And so that you can be seen in person, and we have protocols in place that would both keep other patients safe and keep the providers safe that are taking care of you. With all that being said, most people will call to get an appointment and they will not have symptoms of COVID. And so then your appointment would be scheduled as it normally would and as you're used to having. If you do have an appointment with us, we are asking that unless you are in need of a caretaker that is there to assist you, either physical assistance or help with cognitive functioning, such as need to be able to answer questions for your loved one, etc. We do ask that you come to the clinic by yourself unless you need that person. Again, this is really just in an effort to limit the amount of people that are physically in the clinic at any given time. We are really trying to not use our waiting room. It is a small waiting room, which does make it difficult to socially distance. And again, we want to keep people safe. So when you arrive for your appointment, you will be screened at the door, much like you would at the hospital. You'll be checked to see if you have a temperature. We do that with a skin temperature. It sort of just looks like a little infrared probe. You'll be asked again for symptoms that are to see if you have any symptoms that are consistent, and you'll be given a mask to wear. And we do require that the mask be worn the entire time that you're in the building. You will not be sitting in a waiting room. You will be taken directly to a patient room, and in there, then you'll wait for someone of the flow staff to come in and take your vital signs, go over your meds, all the things that you really are used to having done. The difference that you will notice is that the person will be wearing a mask, and we are all wearing face shields for all appointments. I know you're used to having testing done at the Lyme Clinic, and we are still doing that. So we are drawing labs, and we are doing all the other testing that you're used to when you have your appointments with us. However, we are not currently scheduling lab draws. So in other words, we'll draw labs if they're needed when you're at an appointment, but we're not scheduling lab draws at this moment. That may change. But again, the reason for that is because it is our flow staff that does these blood draws. And at times, if they're busy, people could end up waiting for a while. And we are trying to avoid having multiple people waiting in the waiting room. And then once you are done with your visit, you will, if you need an after-visit summary or something that explains take-home points, so to speak, your provider will print that after-visit summary for you, and then you'll be able to go. If you need additional appointments, tests scheduled, etc., then our exit staff will actually call you at home to set those up, as we are not doing face-to-face exit. Again, most of this is all that we're doing is to sort of increase the flow. We're still seeing as many patients as we did before, but we've changed the processes so that, again, we can keep everyone safe and move things along without undue exposure that people don't need. I'm really looking forward to the question and answer session. Certainly, I'll review the chat and hopefully be able to answer any questions that you guys may have. But with that, I'm going to pass things off to Dr. Caudle Schlossberg, who will be the next presenter.
So, good evening, everyone, and thank you for attending this evening. Given my position as the last speaker to make opening comments, and particularly given the caliber of speakers preceding me, I thought it best to use this time to give you some background on the Lyme COVID response to date. Emergency management is all about waiting and preparing for the community-wide disaster you hope never happens. It typically involves local fire, police, and first responders, our FAST squad. We've practiced for infectious disease disasters, how to vaccinate or distribute life-saving medication to large populations, how to set up mass casualty centers to care for large numbers of injured or ill. So in mid-February, members of Lyme's emergency management team were taking note of troubling events that indicated a new virus was emerging that could create a global pandemic. At the end of February, we began talking about the possibility of the pandemic coming to us from our south, where the largest international airport and population center was located. We began to wonder what we might need for a response. We began by identifying local Lyme organizations and invitations to become part of a community team that could inform our response were sent out. 2 days later, on March 2nd, Grafton County had the first case in New Hampshire, and we were off and running. But wait, there was no life-saving medication treatment, and no vaccine, and no prior exposure of the entire population. We were all vulnerable. In addition, there was limited testing and limited supplies of masks, goggles, gloves, and gowns to protect us, plus limited information. And we knew that what was coming didn't sound good. What we learned then and in the months to come was that it was going to take a village to protect the village, and this is how we approached it. On March 3rd, one day after the first case was identified in New Hampshire, 17 representatives from local organizations formed the Lyme COVID response team and began meeting. In addition, when their duties allowed, Police Chief Sean O'Keefe, Fire Chief Mike Mundy, Fast Squad Captain Lisa Reyes, and Deputy Health Officer Michael Hensley also joined the calls. The team functioned as a collaboration of entities with deep roots into the community structure. We met twice a week, sharing information, activities, insights, and concerns. We tried to guess as to what might happen next and how to prepare for the what-ifs. Judy Russell represented the town library. Martha Tecca, Patty Jinks, and Kathleen Sharib, Community Care of Lyme. Kevin Sarr served both as Select Board Representative and Deputy EMD. Lyme Nursery School was represented by Kelly Downing and Jody Rich. Crossroads Academy by Head of School Brad Choate and Kathy Barth, school nurse. The Lyme Elementary School was represented by Principal Jeff Valance and school nurses Rose Mouse and Laura Dwyer. The Lyme Parish Nurses were represented by Carrie Allen and Sharon Morgan, and admin Terry Hontus. Lyme Congregational Church was represented by Bill Waste, who also served his role as the Public Information Officer. With this organizational structure, we could implement the 3 steps necessary for an emergency response: share available information, make a plan, and take action. Information on developments, recommendations, resources, and guidance were all shared through multiple venues with the assistance of Bill Waste. Bill also assured that our local businesses received the latest guidance from the state. Judy Russell created a COVID page with the latest COVID updates and resources on the library's website. In addition to the state's 211 number for information, CCL People to Helpline. Our goal was to use the existing organizations to distribute information and provide support for the community while we all struggled with the new norm. We wanted to assist in keeping the community safe while supporting access to unmet needs. Once again, the town responded with an outpouring of support and enormous creativity to keep us all sane, hopeful, fed, supplied, entertained, and in touch. Special thanks to the citizen initiatives of Stephanie Carney, Steve Small, and Barbara Wilson, and to local businesses whose efforts, including our local restaurants, the Lyme General and Lyme hardware stores, kept us going. The schools, parents, and children were especially challenged with this new norm and the total disruption to daily routines. As schools closed, jobs were lost or curtailed, and childcare became a distant memory. School staffs led by their respective leaders, Jeff Valance and Brad Choate, are to be commended as plans for online learning moved ahead. Parents and children are also to be applauded for their perseverance. Little ones at the Lyme Nursery School began to meet over internet venues as well. These changes and their challenges probably never seemed resolved and rarely optimum, but everyone pressed on. The potential for food insecurity needs were identified early on, and Kathleen Sharib and CCL developed a plan to implement a solution with the food pantry. Meals for Neighbors, Super Care, and Veggie Care continued with their independent missions, providing comfort, a meal, and sharing the message of a caring community. A plan to assist the community in meeting the recommendations for wearing masks was accomplished through donations from our amazing community seamstresses. As a result, hundreds of face coverings along with thousands of surgical masks were distributed by CCL and their system of 30 Lyme neighborhoods, complete with captains, led by Dan Freihofer. Lisa Salone managed the volunteer training and service program of CCL. So there is still no absolutely safe way to go out into the public again at this moment. This opening up is an experiment, and it's even possible because you as a community practice the essential mitigation habits. Risk is still determined by age, health, exposure to the virus, mediated by both dose of virus exposure and length of time of exposure. And yes, following the case numbers is helpful, and the guidance of the CDC and the state for many activities is recommended. This summer, you can be safer by following some simple recommendations. Stay informed by periodically checking the CDC and NH COVID-19 website for the latest information or through the Converse Library webpage. Prepare going out kits for you and family members and place them in cars, purses, or by the door so you see them on the way out. And continue with the mitigation practices of frequent hand hygiene, 6-foot physical distancing, and mask or face coverings. This is the time to take stock of supply levels, reread instructions, or to go looking for those hard-to-find objects like hand sanitizer. Relocate your instructions for preparing for COVID infection at home, titled Getting to Well with COVID-19, or contact me for another copy if you can't find yours. Check that you have a working thermometer, or consider getting one if you don't. Review emergency plans and supplies for staying in place in case of severe weather or other emergency event, and refer to emergency management on town website for recommendations for COVID-19 and fact sheets for heat waves, flooding, thunderstorms, wildfires, and drought. As we have learned so well during the last 3 months, it is possible to be safer with a pandemic at our doorstep. It will take the continued efforts of everyone to keep us all COVID-free. However, if you do become ill, stay home and contact your healthcare provider. Remain isolated from other family members until you have been COVID tested. Know that as a community, we will be there to help you get through that too. And come winter and fall, the Lyme COVID response team will still be there as well. But for now, we wish you a safer summer.
Thank you very much. I want to express my appreciation to all of our speakers. I think that we have learned a great deal this evening. Some things we knew already, but it's always good to get reminded, and some things that show us that the future is a little bit unknown, but we certainly can be prepared for it. And I am ready right now to take some of your questions if you would like to share any in the chat, or if it would be great if you could do it through the chat. But if you need to raise your hand, that's fine too. While we're waiting for some questions to come in, I do want to remind people that community care continues to be there to serve whatever your needs may be, and the best way to reach them is by either calling 795-0603 or emailing help@cclyme.org. Just checking to see, and as you type your questions, I will raise them to the panel. I have a question that I will jump in with, and whoever wants to answer, just please go ahead and start. And we're perfectly open to having a conversation among the panelists as well. So we were hearing this idea more recently, that more testing equals more cases, and that's throwing off the numbers and causing people to be maybe more concerned than they need to be. I wonder if one of the panelists might have anything to say about that concept. Dr. Talbot.
I track this very closely with the state and also nationally, but we follow the number of tests done, surely. And right, simplistically, the more we test, the more we find. But there are also indicators that the epidemic is actually increasing. For example, the number of people who are hospitalized. So we wouldn't be seeing that if there weren't an actual increase in the number of cases. We also track the proportion of tests that are positive. So, for example, Brazil is in this incredibly steep phase of their epidemic, and they have a 31% positivity rate, meaning that they're missing a whole lot of cases. The target is more for 4 or 5%. At New Hampshire, we've been very consistently at 2 to 4% positivity. So even though we're testing a lot more, that proportion positive is not coming down. So I think that it's more than just the number of tests that are being done, absolutely. So we certainly would understand that very simple concept and hope that you'll trust we're looking at more than just the number of tests, right?
Thank you. That puts it in greater perspective. I appreciate that. We have a mom here asking if any of the panelists can provide some direction around recommendations for safety at Post Pond, that's our local swimming hole, for kids and families.
I can start, and we'll see what else folks know. I've not been to Post Pond. Sounds nice.
It is very nice.
It's really all about social distancing. So we know family units will stay together, but how do we make sure that people aren't just doing what humans do, getting close with people that they want to reacquaint with and say hello. So even at the beach, we're going to be getting funny tans. But really, if you're going to be anywhere in proximity to others, it makes sense for me just to consider it like the supermarket in some ways if you're going to be spread out on that beach. The water itself doesn't pose a risk, so I just want to be clear about that. Anything else to add to that, Dr. Altamari or Powell?
Yeah, that's what I was going to say too, similar thing. It's really being cognizant of the others around you and giving distance. Mask, of course, is recommended, particularly if it's difficult to stay farther than that 6 foot distance. But yeah, unfortunately, not everyone will wear masks, and I think that it's important to sort of take that upon yourself to give the wider berth. To protect yourself.
And Elizabeth, I'm not sure if you know more than I. I've tried looking this up. I see related questions coming in specific to kids and kind of the epi and transmission related to children. And when people have said, well, children can't give it to each other, I've not found evidence that that is the case. I think it's still transmissible. Why children are disproportionately unaffected, I physiologically don't know the answer to, and I don't know if you have a better gleaming, idea about that. You're on mute, Elizabeth.
Yep. You've heard it so many times that age is the risk factor for the most severe outcome. Right now we know about 3.5% of all the U.S. cases are in children. And I think it's fair to say that some reasonable talking points are children are less likely to be even infected than adults. So probably half of the infection rate that adults have, and also that they are less likely to be symptomatic. as well. So 20% of children have symptoms, whereas 70% of adults over the age of 70 have symptoms. So you can see that there's really big differences between children and adults. But children do transmit to adults. So we've had a lot of pushback on the disruption of school closings to kids, and I get it. I mean, there's so many things to weigh in this horrible epidemic, but we don't want children passing one to another and then bringing that disease home to those who are more vulnerable to disease.
Thank you. Before we move to what I see are a number of questions about creating bubbles within your family or your social circle, and more questions about travel, I want to make sure that we address a really basic question that a lot of people are still wondering about, and that is surfaces and sanitizing or disinfecting surfaces. I have a lot to say about it as a librarian and the research that's being done in my field, but generally speaking, what would be your advice to people on that? Anybody? You could start, Dr. Talbot, since we have you.
Okay. Yeah, well, of all the terrible tricks that this virus has, it doesn't seem very efficient for it to transmit this way. So it's fragile, in fact, and it falls apart in sunlight generally after minutes or hours. It gets destroyed by a lot of the different cleaners. And yes, I do think frequently touched surfaces should still be cleaned very regularly. Those are the handrails at the grocery store, cart and doorknobs and whatnot, where a lot of people are using them. So that still makes sense to me. I think as I glanced at the question, it seemed it was largely about cleaning at home. Mm-hmm. But if you're in your own safety bubble, you got to think about, how did the virus get there? Do I really need to clean it? So I'll maybe ask Dr. Altamari to follow that up with any coherence you got for us.
Yeah, thank you. And Dr. Altamari, that I think if you could just, after that, address this concept of bubbles, that would be great too.
Yeah.
Sure. So yeah, cleaning is always recommended, just routine disinfection. And this becomes actually more important as we enter into the fall with other viruses that are circulating, including influenza. But like Dr. Talbot said, the primary mode of transmission really is person to person through droplets. And unless you have someone actively contaminating a surface and then quickly touching that surface and then touching your mouth, your eyes, your nose, that's really how that transmission is going to happen. So if you do have people coming into your house that are kind of breaking your quarantine or your bubble, if you will, then making sure to disinfect, the high touch surfaces, which really are the light switches, the door handles, the faucets, the toilet flusher, things like that. So with regards to the bubbles, I suppose it depends on how isolated your bubbles are. And certainly if there's two families or close friends or neighbors that have been quarantining and truly quarantining together and have been interacting with no one but each other, then it seems reasonable that that would be a safe bubble to continue to interact with. The variables come into play as to which people in the household are coming and going and introducing new things to one or both of those bubbles, that it becomes a little more unknown as to what's going to happen. So it depends on how confined those bubbles are to know whether it's safe or when it becomes unsafe.
Yeah, I'll jump in too. I think a lot of this too is, how big a bubble do you have, et cetera. It really comes down to communication and trustworthiness of the individuals that you know. So in other words, is it someone that you're frequently with? Do they take all the proper precautions? Do they social distance? Do they wear a mask? Are they around people that wear masks, et cetera? Certainly you can have friends over to your home and all of you wear masks. But I think it's really of a time where we really need to be open, honest with one another, talk about our practices, and ask the questions. To do the best you can to be safer.
Any other comments on that? I might jump in if the panel doesn't mind and just address the surfaces question with the library, because I know that Lori's earlier version of the question asked about the library as well. And we have decided, if you did see my email today, that we are going to continue to quarantine our items for 72 hours. A very specific to libraries report was released today, and while it does agree essentially with what Dr. Talbot said, that on most surfaces the virus or particles of the virus disappear within 24 hours, there are particular surfaces where it seems to take more like 72 hours. And one of those surfaces, strangely enough, and I guess it has to do with oxygen, but are the pages inside a book. And the other surfaces are the particular types of plastics that we use to cover our books. And they have a different type of permeability, I suppose, another chemical makeup. And so that is why we have continued to have you return your books in the manner that we have been doing, and that will continue through July at this point. But we are very happily lending books out and taking good care of them when they come back, so they're safe. Thank you. So I see a question here. Has the state task force on reopening school given any sense of when they might come out with their recommendation? I suppose Dr. Talbot might have the closest connection there.
So it's there's a dedicated group led by Commissioner Edelblue in education. And we have only heard some of the hints around the fact that we are going to have to remain flexible. And there are going to be some changes to the way that we administer education to kids. And I think there may be shortened days, there may be changes to vacation schedules and the like. So a lot may change. Just to do a little foreshadowing here, those guidances are likely to come out in about a week. Is what I'm told. So these are guidances. That means that your own schools may take a slightly different approach because we all have to be humble that we don't know the right way to do this. We don't know the best way to do this. We're learning from others. We're trying to take best practices. But in fact, there will be some flexibility to different schools under different epidemiologic circumstances, like low rates in Lyme, for example.
Mm-hmm. Thank you.
Judy, can I jump in to ask a question?
Please do.
Dr. Altamari? Being as that I'm an internist, I don't really know the answer to this, as I don't take care of children, but I'm wondering about our mobile testing clinic. Is that available for children? And if not, how do we get children tested if they have symptoms of the disease?
Yes, so our mobile testing unit tests anyone who meets criteria. Right now, essentially the way it was set up was people have to have a provider within the Dartmouth-Hitchcock system or be an employee or family of an employee in order to get the order placed in our system. But there's ways around that as well to get people tested. So if you wanted to get a child tested, you'd simply call their primary, their pediatrician or family doc, and then the family doc would call our COVID hotline and we would arrange testing.
Thank you. I have a question here about masks and about how we're seeing a change in the numbers of people who are or are not wearing masks. And the question has to do with the safety of the masks we are wearing now that there are fewer or less, let's just say, people wearing them. Should we have a higher grade mask in order to protect ourselves better if there are fewer people choosing to wear them? Interesting question.
The question was going a different way. So can I answer the question I thought you were going to ask? Or, okay.
Yeah, sure. Then we'll go there.
Well, I do think it's coming to my ears a lot that people are noticing that we have battle fatigue, right? That it's just we're all getting tired of the inconvenience and the breach in what is a typical way that we interact. I mean, see Dr. Altamari in the hall, and I can't always tell if her eyes are smiling, you know, and I love the notion. In Switzerland, they've developed actually translucent masks, so you can still see a person's face through it. So I hope that'll come to us, because I'm afraid we're in for masks for a long time. You know, I have to say it, the data is consistently favorable toward reducing community transmission through the use of these face coverings, either the cloth face covering or the surgical mask. I would not use a higher grade mask in public space, because these are especially fit tested to create a seal, and they may not serve the purpose you believe. They may even in some circumstances be counterproductive, because they generally are less comfortable, harder to breathe, people are adjusting them more and potentially inoculating themselves. But now let me defer to Dr. Altamari as well. Go ahead, set me straight.
Yeah, so what I was going to say is my teaching is always the mask on your face is to protect me, and the mask on my face is to protect you. So really what we're trying to do is get people to wear masks so that they themselves can prevent spread to others. So wearing the masks in public or any kind of face covering is really the goal. The type of mask really it's not there to protect you from getting the virus. And like Dr. Talbot said, anything higher than the usual cloth or medical grade face mask is really unnecessary, because it really does need higher level fitting to your face. And at that point, it functions just as a regular mask would. And to Dr. Talbot's point, we actually do have the clear face masks at the hospital, particularly for our hearing impaired who have to lip read, which has become a challenge. So in addition to the sign language and the lip reading, it's been very helpful.
Oh, I'm really glad to hear that. That's great. I have a question for Dr. Cadell-Schlossberg. We have an audience member wondering about cleaning practices for items from grocery stores and other shopping prior to bringing them into the house.
I think that the recent literature talks that this can be done fairly safely in terms of bringing the things in, just setting them aside and making sure you wash your hands before you go about business afterwards. That again, this idea of the fomites on the surfaces, if they're there, and that means somebody has directly coughed or sneezed on the package that had COVID. So there's a lot of circumstances, I think, that would make that unlikely possible. So that's why you do the hand hygiene after you come home and put things away. But to scrub things down with disinfectant, packaged boxes can seem to be a line that can be drawn in terms of disinfection. I don't know if you would agree with that, Dr. Talbot and Dr. Altamari.
So I'm hoping Antonia would answer. Because we all want to be as safe as possible. I also feel like in some ways we also have to choose the best ways to put our energies. And I want to say it again, that the majority of this transmission is person to person and not so much on these fomites or objects. And CDC recently came out with a statement, said, yeah, we didn't really find all that much transmission that we could clearly attribute to objects. And yet I know people are spending lots and lots of time scrubbing and cleaning and, the groceries and the cans and the whatever. So I just do want to say, use common sense. What are the chances that that object has been contaminated by somebody who's infected within really the last day, right? And then use some common sense approach while you're making sure that you have your cloth face covering in place, right? So
one of the things that we've not talked about too much, but I know remains central, is hand washing.
Sure. Hand hygiene, we like to say, because
hand hygiene.
You have to keep scrubbing your hands with soap and water. And this isn't a very, again, sexy topic in terms of way to control it, but boy, does it work. Yeah. So, go ahead and commit to it. And if you can't find Purell or the alcohol-based hand gel that you like, you can even make it. There's recipes online. Mm-hmm. So this you need to figure out. That's another thing to really put your energy to. Not so much scrubbing the bottom of the potted plant and but really having it in your pocket and having it in your bag and making sure there's one in your car and like, look around now, where is it, right?
Yeah.
Because that's what could really make a big difference for you.
Great.
I agree. I think, just to tag on to the trying to clean all the objects you're bringing into your house is really unnecessary if you just wash your hands after you touch them, because the real deal is taking your hands and putting it up to your face or eating something once you've touched it. So it's really unnecessary to clean the item and more necessary for you to just clean your hands.
Mm-hmm.
Yep, good one.
Yeah.
Right, and I think piggyback on that too is as Dr. Talbot had mentioned, this virus is mostly spread from person to person. So it's actually, I would say, more important to follow those arrows on the grocery store aisles and doing proper social distancing, etc. You'll get more bang for your buck than actually.
Okay, we're at about 8:25, and I think that we had talked about ending around 8:30. I know we did start late, so I have two more questions that have come in, and I have one scribbled down here myself. Let's just touch on travel yet again. I think people have a lot of questions about leaving the state, then coming back. I do want to say that I am going to work to go to all of the local, the northeastern states' websites and try to share that information on the library's COVID information page as regards travel and self-quarantining. This particular question, panelist says, I would like to know what the recommendations are for returning to New Hampshire if you've traveled to other states. No particular state, and I know it changes from state to state, right?
I would say we have our state bubble, right? So Vermont, Maine, and New Hampshire are just as you're talking about family bubbles. We're a state bubble in some ways, but otherwise, if you travel to other states in your own personal vehicle, then that's a far less riskier thing than being on public transport. I saw some shocking data. Let me just give you the order of magnitude of what happens in airports. But at the Miami-Dade airport, they tested every one of their staff members. Just think, what percentage of the people working at the airport do you think were positive? 52%.
Oh, wow.
So that's where the danger really is. I mean, obviously, if you're going to a wedding or something, you have to social distance. If you're going to any of the other states, but in general, it's really bang for the buck. The phrase again, it's on that public transportation that we think transmission has really been amplified, or these so-called super spreader events. So again, I just want to mitigate your expectations and help you to focus on where the biggest risks are.
Right. Good. That's good and specific, and that's what we need, I think. We have a question from a school nurse asking about masks and asthma and whether or not it is an issue for children with asthma to be wearing masks.
So if it creates anyone difficulty breathing, sometimes it's anxiety, sometimes it's COPD, sometimes it's asthma, then that person really has to be exempt, and they have to fall back on using alcohol-based hand rubs and other mechanisms. But in general, there is not that link. We don't believe that wearing masks will exacerbate asthma as a general rule. Does that sound right? Other clinicians? Lifeline? Okay,
I see nods.
Yeah,
Lifelines.
It's uncomfortable to wear, certainly, even for someone without asthma or breathing issues, but it shouldn't precipitate it. The one thing to note, though, children younger than 2, the recommendation is against using a mask for safety reasons.
Oh yes, that's right.
So it should not be put on a 2-year-old or younger.
Under 2 or younger. Yeah, I have seen some babies.
Or persons who have dementia and might pull at it, especially if there's one with strings. This can be dangerous too.
Okay. My question, and you may have touched on it a little bit already, Dr. Altamari, but in talking about antibodies, but I'm wondering about the usefulness of people who have been tested positive for the antibodies in terms of any further research on vaccination or immunization. That's really for anybody. Is that something that people should seek out so that they can be of help in a good way?
I can start by trying to answer. I think the question, I suppose the answer right now is that the presence of an antibody does not mean you're immune. We don't know that for sure, and that's what we're hoping to learn. So with vaccine trials, I don't know if we would be approached having such a low prevalence of disease in our area for a possible vaccine trial. But right now, if you get an antibody test, it's not going to change our management. I think as we learn more information, my hope is that we can use that information. And whether it's herd immunity with time or a combination of infection plus the vaccine, we will have enough people immune that this may become part of our normal circulating virus, that we may need routine immunization, maybe not, maybe it'll die off. It's hard to know. I think some of you probably remember the introduction of H1N1 into the United States and how we rapidly were able to get people immunized. That's something we still immunize for on a yearly basis, and it's just become part of our circulating virus from season to season. So I think there's just still a lot unknown about what those antibodies mean and how we're going to use them going forward.
Yeah, and I'll jump in here too. And so at Hitchcock, we actually, and multiple places across the country and the world for that matter, are doing antibody work, looking at what are these antibodies, where are these antibodies, and do we have, quote, neutralizing antibodies, which antibodies that neutralize the virus. So that work is being done. And collecting samples from patients. The difficult here, and I think important to remember, is that this takes time. Even if we identify neutralizing antibodies, et cetera, we don't know how long those antibodies will be there, and we have to study patients over time who have had the illness to see do those antibodies stay for 2 months, 3 months, 9 months, the rest of your life, and we just don't know. And so those studies have to continue, and we can't speed up that process any faster.
I'm back. Sorry about that. Thank you, Dr. Powell. And Dr. Cadell-Schlossberg, I have a question here. Early on in your planning and implementation of guidance, how did you identify those in your area that didn't access the internet for receiving information? Do you attempt to accommodate with hard copy everything you put out, or focus location-specific distribution of information like grocery stores for widespread coverage?
It's a good question, because that has been one of the biggest challenges. Not only do we have limited internet and no way of knowing exactly how many people use it, sometimes the internet doesn't work that well. So it's been a constant challenge. So we've done the really important things. We've sent direct mailings to all households. We now have the neighborhood captain programs so that we have ways of distributing through this network of 30 neighborhoods and their captains any information that is critical that needs to be gotten out to the community, and as well as anything that needs to be handed out, like the masks were. So we do have mechanisms. It's just a lot more slow and challenging to do that without using the electronic means.
Thank you. Yeah, and I would add too that right now it's Wi-Fi on the outside of the building, but ordinarily the library serves as a place for people who do not have internet at home or the equipment to come and work on these computers or be guided to be able to read that information. But we certainly are trying to reach people in as many ways as possible. Thank you. I'm gonna make this the last question and let everybody have a shot at it. What is the panel's advice about getting tested if one is asymptomatic?
I'll start. I get the question a lot, so I think it's a great question, and I think the first thing we should do is make sure we're being extremely intentional in the language we use around testing. So to get the PCR test versus that antibody test. So just to be very clear, I think the question is around getting that PCR test where they put the swab in your nose and sample the back of your brain kind of thing. Not really. And that makes sense to me if you're a person who's had an illness or has an illness, even the mildest of symptoms, or you're a person who takes care of someone who's very vulnerable to outcome, like if you're a caregiver to someone. Certainly if you work in healthcare, and you might inadvertently shed viable virus to someone. But in general, I don't think there's a lot of utility for the average citizen to run out and get that PCR test, especially if you've been doing what you should do regarding your hand hygiene, your masking, your quarantine, and et cetera. So now let's hear what others have to say about that.
Okay.
Yeah, I'm glad you went that way. I was a little worried about it. Looking at it on the state level versus the provider level. We get this question a lot of individuals who say that they just want to get tested, and it's initially in the response it was we didn't have the testing supply, so we were saying not to do that. However, now we do have the testing supplies to be able to make it happen. But still, I think my personal feeling is that asymptomatic is it's not incredibly useful. It's unlikely to be helpful, except in those circumstances that Dr. Talbot mentioned. Certainly, particularly if you're working in a nursing home or something along those lines, that if you're asymptomatic spreader, you could really cause pretty massive devastation. But I personally believe that yes, if you have symptoms and they may be mild, that it's warranted testing. But if you're asymptomatic, I don't think that it's the effort is, because again, it could be negative, but that doesn't mean it's not going to be positive in 2 days.
When you develop symptoms.
When you develop symptoms.
Dr. Altamari?
I was going to say, I agree with what everyone said. And I think in the beginning, we also had a lot of trouble interpreting these tests because the test platforms we have really have only been validated in patients who have symptoms. So if you get a positive test in someone who doesn't have symptoms, that's good, you're lucky, but there's a lot of times where you may actually be infected and the test may not pick up on it just because it hasn't been validated in that population. And so again, unless there's a reason, either you're being asked to be tested or there's you're going in for a procedure that requires testing ahead of time, that may be indications to get tested. But otherwise, there seems to be little utility outside of the healthcare setting.
Any final words, Dr. Cadell Schlossberg?
I read something this afternoon about the insurance companies saying that, we really can't pay for everybody getting tested if, just because of this. And I certainly appreciate the pull to be tested. But as I've learned from Dr. Talbot, listening to her DHHS calls every week, for that one point in time, it's all the information that you're going to get, you're positive or negative. And after that, you're still going to be at risk. So the thing is that it's best to use it for an indication that's pretty clear, has already been described.
Thank you. Well, I want to thank everybody here. Thank you, audience members, for attending and for being so understanding about our format and following all of the guidelines. I really appreciate it. I think it couldn't have gone more smoothly. And thank you, panelists, for your expert knowledge and the optimism that you are leaving us with. I mean, I think that we all hear you, that you want us to continue to stay safe and social distance and wear those masks, but we're doing a good job. And if we keep doing what we're doing, and be careful this summer, because I know the opportunities to change those guidelines are very tempting. So that is it. Sharon Morgan, I saw you pop on, and I wondered if you or Carrie have anything else that you would like to say before we close this evening.
Well, I can speak for myself, and if anyone has any further questions, the parish nurses, you can always give us a call as well. And our number is listed in the book, and we welcome any and all comers. So thank you all. This has been wonderful.
Thank you, Sharon. And I think that Dr. Cuddell-Schlossberg would agree with me in that we want to emphasize with everybody that the Lyme Emergency Response Team has, we've slowed down our work a little bit, but we're still here and we're still trying to be creative about the ways that we deal with this, and we're here to answer any questions and to provide any services. So with that, I will say good night, stay healthy, be well, and take care.